Hi everyone. So today we are going to deal with the topic which is Rh negative pregnancy. Now remember in obs and gynae, whenever we are dealing with some topic, we are more concerned about the mother, right? Not the fetus. So Rh negative, it's easy to remember. We are talking in respect of the mother, right? Or the female. So if the mother or the female is Rh negative, then we call it Rh negative pregnancy. Okay. Now remember, what do you mean by Rh negative? On the surface of the RBCs, we have many antigens, right? There are many antigens, out of which of importance are capital C, small c, capital D, capital E, and small e. These are the antigens on the surface of the RBCs, universally present in everyone, right? In various combinations. Now, if this capital D antigen is present on the surface of the RBC, then we call that person Rh positive. And if this capital D antigen is absent, then we call that person Rh negative, right? So this concept is clear. Remember, there is no small d, it's just capital D present or absent, and in that term we call it Rh positive or Rh negative respectively, right? Now remember that a female is Rh negative, right? So this female might have married a Rh positive male or a Rh negative male, right? Either of them. Now see, if this female Rh negative has married an Rh negative partner, then in that case we will obviously have a fetus who is Rh negative, right? The fetus is going to be Rh negative. Okay. Now, if she has married a Rh positive partner, then there are two possibilities that the fetus could either be Rh positive or the fetus could either be Rh negative, right? So, when are we calling this a high risk pregnancy? When the mother is Rh negative, the partner was Rh positive, and hence the fetus also turned out to be Rh positive. There's a 50% chance in this case that the fetus is Rh positive. When this scenario is present in an individual, particularly Rh negative female with the Rh positive fetus in utero, then that is called a Rh negative high risk pregnancy, right? Now, this high risk pregnancy, why are we calling it high risk? Or, in other terms, what is the problem with this high risk pregnancy where the fetus is Rh positive and the mother is Rh negative? Like, why are we calling it high risk? The problem in this combination is that whenever there is feto-maternal hemorrhage due to any cause, right? Feto-maternal hemorrhage, it could be bleeding, it could be due to versions, or if you do some invasive procedures, right? In that case, there could be a feto-maternal hemorrhage. Now, what will happen next? Now, we try to understand this in forms of a diagram. Suppose this is the fetal circulation, which is Rh positive. These purple antigens that you see on the surface of the RBCs, what are these? These are Rh factor or the capital D. And this woman, this fetus is Rh positive, right? This is supposedly the placenta, and this is the maternal circulation, right? On your right hand side is the maternal circulation. Now, on this maternal circulation, you see there are no antigens of the surface of the RBC, or this woman is Rh negative, right? So remember, in that case, when there is a first pregnancy in this woman, okay, she's pregnant for the first time, right? Okay, so what will happen next when she's pregnant for the first time? What happens that due to feto-maternal hemorrhage, the blood will come in contact, right? The fetal blood will come into the maternal circulation, right? It came into maternal circulation. Now, if this Rh positive antigen containing RBCs come into contact with Rh negative ones, what will happen in response? These Rh negative RBCs will produce what? Antibodies, right? What are these antibodies? These are anti-D antibodies, right? So these antibodies which are produced are of IgM type, because this is the first pregnancy. This is the first time that these Rh negative RBCs have come into contact with Rh positive antigens, right? So the first one produced is IgM, okay? And this is mostly harmless, okay? Because it is the first pregnancy, it's IgM type. IgM type cannot cross the placental circulation, so it is of less concern to us. But if this woman is subsequently pregnant for the next time, again with an Rh positive fetus, what will happen? Once again, it will elicit an immune response, and IgM as well as IgG antibodies will be produced this time, right? Why IgG? Tell me. Because there is going to be a second exposure to those antigens, right? So these IgG, we all know, can cross back. It can cross the placenta and reach the fetal circulation. Okay, so these IgG antibodies, they've reached and the fetal circulation. And what were these? These were Rh positive antigens. Now tell me, if antigen and antibodies combine, what will happen? There'll be an immune reaction, right? They have combined, they cause the reaction, right? Now what next? Because of this antigen antibody reaction which is happening on the surface of the RBCs, there is going to be cell lysis, right? So there is going to be lysis or breakdown of those RBCs, okay? Now, because of lysis or breakdown, since they're happening on the surface of the RBCs, what will happen? Anemia. Why? Because the RBCs contain hemoglobin, so it will go down. There'll be anemia. Following anemia, what will happen as a consequence? Jaundice. Definitely, the fetus might have jaundice. Again, as a consequence of anemia, hyperdynamic circulation, again the heart is not getting enough blood, so then there might be heart failure, right? Now remember, one more thing, that in order to compensate for the anemia, what will happen? In order to compensate for the anemia, the fetus, bone marrow and other areas, they're going to produce what? More and more RBCs. And when they try to produce and compensate these RBCs, what is this condition known as? This is known as erythroblastosis fetalis, okay? Erythroblastosis fetalis, or nowadays also known as hemorrhagic disease of the fetus in the newborn, right? Hemorrhagic disease of the fetus in the newborn. Okay, so erythroblastosis fetalis. Why? Tell me. Erythro means RBCs and blastocysts means precursor cells. Anywhere we use the term blast, we means precursor cells, because they're trying to compensate, so they're producing more and more immature or the precursor cells, right? So this could be one consequence that can occur, which is erythroblastosis fetalis. Again, because of anemia, there could be another finding, which is hydrops fetalis, right? Now, what is hydrops fetalis? Remember that this is entirely a USG based diagnosis. It's not found clinically, okay? You have to find it on the USG. So as a result of lysis or breakdown, there could be anemia, there could be jaundice, there could be heart failure. Because of increased RBC production, there could be erythroblastosis fetalis or HTFN, or there could be hydrops fetalis as well. So once again, trying to understand in terms of diagrams, see, this is the fetus containing that Rh positive blood, and this is the mother having the Rh negative blood, right? So now when it goes into contact, the positive comes into the maternal circulation, right? And what will be produced? Antibodies. These yellow color that you see, antibodies will be produced, okay? Once again, going to another diagram, right? So in the first pregnancies, this is Rh positive fetal blood, which is coming in contact with the maternal circulation, but nothing happens in the first pregnancy. But in the subsequent second pregnancy that you see, fetal Rh positive blood is then attacked by maternal antigens, because it has now crossed back into the fetus, right? Now, this is just a USG depiction of hydrops fetalis. Hydrops fetalis on USG can be seen in terms of scalp edema, pleural effusions, ascites, pericardial effusion, right? So in this, we've understood what is Rh negative pregnancy, what is the problem with Rh negative pregnancy, because there's a lot of problem that could occur in the fetus. So we don't want that. So we want to manage Rh negative pregnancy at the earliest. So now we are coming to the management of Rh negative pregnancy. Remember, whenever you find a female who is Rh negative, first thing you do is ask for the partner's blood group, okay? Ask for the male partner's blood group. If the male is also negative, then do nothing, obviously, because 100% fetus would be negative and there'd be no sensitization, okay? So do nothing, okay? Do nothing. But if the partner is positive, I explained before that there is 50% chance that the fetus could be positive, right? So what do? You take the mother's blood and do ICT, or the indirect Coombs test, to find out whether she has those antibodies or not, right? Right, so now there are two possibilities. The ICT could be positive or the ICT could be negative. We go to the part where ICT could be negative, where ICT could be positive. Now remember, please try to understand, whenever the ICT is negative, what are we testing for? We're testing for antibodies in the maternal circulation, okay? So if the ICT is negative, which means that the mother does not have those antibodies, right? So if she does not have those antibodies, then we can say that the mother is unsensitized. She does not have those antibodies yet. So now whenever you find an Rh negative mother coming to you, please do an ICT at the first visit, okay? Also do an ICT at 28 weeks of pregnancy, okay? Why at 28? I shall explain. You do ICT again at 28 weeks of pregnancy, okay? If still the ICT is negative, no antibodies are formed, what you do is you yourself give antibodies to her, okay? You give her anti-D, okay? How much? You give anti-D at 28 weeks of pregnancy. How much anti-D do you give? You give her 300 microgram or 1500 international units of anti-D. What is anti-D? Anti-D is an injection that we give, okay? It's also available, it's known as Rogam, right? You can Google and see how it looks. So you can give 300 microgram or 1500 international units of anti-D, which is able to neutralize how much? It is able to neutralize 30 ml of fetal-maternal hemorrhage or 15 ml of fetal RBCs. It is able to destroy, okay? That is how much you administer, okay? And what will happen if you give this anti-D at 28 weeks? Remember, that is, it is able to prevent any sensitization in the present pregnancy, okay? In the first or the present pregnancy, okay? So what is this? This is basically a prophylaxis that you are giving to her, okay? And this is a very small amount, so do not think that giving this anti-D to the mother will sensitize her. It's a very small amount, it won't, okay? So you are doing this in order to prevent any problem that might, or complication that might occur because of this antigen antibody reaction when it comes into contact, or if there is any fetal-maternal hemorrhage, right? So you've given anti-D to this woman. So you have administered anti-D to this Rh negative woman whose ICT was negative at the first visit, as well as 28 weeks of pregnancy. After that, you just carry on the pregnancy normally up to say 39 to 40 weeks, right? You carry on the pregnancy, and later when she has delivered, then you do a direct Coombs test in the baby, right? From the fetus blood, right? You do this DCT in the baby after the baby is out. Now if the DCT is negative, right? If the DCT is negative, in that case, what you do, you give anti-D post delivery as well. Okay, why do you give this anti-D post delivery? In order to prevent any complication that may happen in the next pregnancy, right? So this is also a prophylaxis that you're giving her, not for the present pregnancy, because the baby is already delivered. Okay, so you're giving this for the next pregnancy, right? So this is how you manage a case of Rh negative unsensitized woman or a ICT negative woman. It is said, it is quoted in Williams Obstetrics, that provision of anti-D immunoglobulin at 28 weeks of gestation will reduce the third trimester alloimmunization rate from approximately 2% to 0.1%, right? So you see the reduction in third trimester alloimmunization is so much. That is why we prefer giving anti-D at 28 weeks, right? Now, this is the part where the ICT is negative, that woman is not yet sensitized, okay? But in a scenario when the woman is ICT positive, which means she is a sensitized woman, what do you do next? If she's a sensitized woman, we'll see what to do next. If she's sensitized, simply, which means she has those antibodies in her circulation, what do? You go for antibody titer in her, right? Find out how much antibody does she have. Okay, so antibody titer I've been doing, okay, in this woman. Now see, what is my critical cutoff? That is 1/16. Just remember this value, 1/16. Now see, if she has any value which is more than equal to 1/16, then my management becomes different. Okay, values like 1/20, 1/24, 1/28, 1/30, in those cases my management will be different. But if she has values less than that, which is 1/4, 1:8, then my management will be different. Okay, so this is a less severe form and these are more severe forms. Okay, so what do? If my value is 1/4, 1/8, I can still take some risk. What do? I keep repeating titer at 4 weeks interval, right? I keep repeating titer. Obviously, I'll do fetal surveillance. Okay, I'll keep monitoring the fetus as well. So I'll do fetal surveillance beginning from 32 weeks and I'll keep repeating titer 4 weekly. Okay, and then carry on the pregnancy up to 37 to 38 weeks. I'll carry on the pregnancy. Now, see if it has crossed the 1:16 value or my critical cutoff, then what do? Yes, I understand that it's a severe form of anemia. What do? I will see how severe is the anemia, right? So I will check for the degree of fetal anemia. How do I check for the degree of fetal anemia? How am I going to check? By doing a middle cerebral artery Doppler of the fetus. Middle cerebral artery Doppler and check for the peak systolic velocity. Whether my peak systolic velocity is less than 1.5 times multiples of mean or whether it is more than 1.5 times multiple of mean. Now remember, if it is less than 1.5 times multiple of mean, I can still take some risk. What do? I can keep repeating the middle cerebral artery Doppler. I can still keep repeating that and do fetal surveillance and still carry on the pregnancy up to what? Up to 37 to 38 weeks. I can still carry the pregnancy, right? However, if my mean MCA Doppler PSV is more than equal to 1.5 times MOM, then in that case I can still see how much is the hemoglobin or the hematocrit in the fetus. So I'm going to check the hemoglobin or the hematocrit in the fetus, right? So how do I check for that? I will have to do a chordocentesis. That is, I have to take out the cord blood from the fetus. Okay, so if the hemoglobin in the fetus is less than 30% or more than 30%, remember, if it is more than 30%, I can still take a risk, right? I can keep repeating the hemoglobin and the hematocrit, right? Hemoglobin and hematocrit, I can keep repeating and still carry on the pregnancy up to 37 to 38 weeks by repeating those values and doing a fetal surveillance. However, if it is less than 30%, I do not have an option. If my fetus is more than 35 weeks, like it is mature, somewhat not preterm, not very preterm, right? And if it's more than 35 weeks, then what I can do is I can simply deliver the baby, right? But if it is less than 35 weeks, what I have to go for is my absolute indication. Please go for, I can go for intrauterine blood transfusion, right? I can go for intrauterine blood transfusion. So recapitulating, if the mother is Rh negative, right? If the mother is Rh negative with ICT being positive, which means she is a sensitized individual, she has those antibodies, I will go and check for the antibody titer. Okay, I will go and check for the antibody titer if it is less than 1/16 or if it is more than equal to 1/16. Okay, so if it is less than 1/16, I can keep repeating the titer, go for fetal surveillance, carry on the pregnancy. If it is more than 1:16, then in that case I have to check for the degree of fetal anemia by doing an MCA Doppler. If it is more than equal to 1.5 times MOM, then I can still check for the hemoglobin or the hematocrit by doing a chordocentesis, right? And if the hemoglobin or the hematocrit is less than 30%, then, and if the baby is less than 35 weeks, then I might have to go for intrauterine blood transfusion as well, right? So remember that, did I have any role of anti-D when the mother was sensitized? No. When the mother was already sensitized, there's no point giving anti-D to her. However, if she was ICT negative, then there was role of anti-D, right? So this is Rh negative pregnancy in gist. So this was Rh negative pregnancy. This is anti-D injection that could be given, right? 300 microgram or 1 ml, right? And we have discussed what is Rh negative pregnancy, what is the problem if it is Rh negative pregnancy, and in what scenario. In a scenario where mother is Rh negative and the fetus is Rh positive, then we call it high risk Rh negative pregnancy. What is the problem? What problem will the fetus face? Maternal complications are also there, but mainly due to fetal complications. Maternal complications are also there, but mainly due to fetal complications, we have to keep this in mind, right? And then we discussed in just the management aspect of Rh negative pregnancy. I hope the video was helpful for you. Thank you for watching, and if you like my video, do share and subscribe and press a like button. Let me know how did you like it and if there's any scope of improvement. Thank you.